Research is the cornerstone of innovation in clinical practice, driving improvements in patient outcomes and shaping the future of medicine. Welcome to the Global Rhinology Network Topical Research Symposium. I'm Ashok Rokade from Winchester, UK, and it is my privilege to welcome you as a host. Joining me as co-hosts are Louise Melia from Bath, UK, and Professor Thibault Van Zele from Ghent, Belgium. This symposium showcases fascinating topics across 4 key modules: General Rhinology, COVID session, and Research in Chronic Rhinosinusitis. A special highlight is the PhD session featuring research conducted by enthusiastic young rhinologists who represent the future of our field. This symposium brings together leading global minds in rhinology who will highlight latest developments with a focus on translating research into impactful patient care. The Global Rhinology Network is dedicated to advancing knowledge innovation. Thank you for being part of this exciting journey. Thanks to Medtronic and Karl Storz for their generous support in making this symposium possible. Welcome to GRN Topical Research Symposium.
Thank you, Ashok. It's my great pleasure to introduce a colleague, a very close colleague and also a friend, Philippe Gevaert. He is a full professor at the Rhinology and Allergy Department of Otorhinolaryngology, and he also coordinates the Allergy Network of the Ghent University Hospital. He has been doing a lot of research in the past decades together with Klaus and Professor Van Kouwenberghe, where he focused on local IgE expression, eosinophilic inflammation, both in allergic rhinitis and chronic sinusitis. And he will today talk about the position of biologics, not only in the treatment of chronic sinusitis with pollen, but also in allergic rhinitis.
So thank you, Thibault, for the nice introduction and that I can be part of this interesting panel. I will talk about biologicals in severe allergic rhinitis because I think there is still a lot of patients that are needing better care also in that field. Of course, we all agree that chronic sinusitis with nasal polyp is a severe disease, but there is certainly a subgroup of patients with allergic rhinitis where we don't find the right treatments. And I just want to show you, this is an interesting finding. This is at the pharmacy level. We look at what is used. If the patient comes to the pharmacist, of course, nasal corticoids is high, but also nasal decongestants has been used by the patient wrongly. But what is more striking is that in Belgium, 3% of the patients with persistent rhinitis are treated with systemic steroids. And I think that's not a good thing. So I think we all know that steroids on long-term use for allergic rhinitis is not a good idea. So the idea is, if it works for type 2 disease, and of course allergic rhinitis is also a type 2 disease, what is the evidence, and can we also there in a subgroup of patients go for biologicals? So we have these biologicals. They have been shown before, of course, in nasal polyps. You have seen these studies. I will not go deeper in that. So omalizumab, mepolizumab, and dupilumab. And what is the evidence in allergic rhinitis? Now, we had a PhD student, Jarno de Kraner, and he did his PhD on that. And so he did a meta-analysis, and it's very interesting to see that omalizumab, anti-IgE, there is a lot of evidence on that. And at first, what is interesting is that the first studies in the 90s, end of the 90s, were actually actually also with anti-IL-5, but in asthma, but in allergic rhinitis, there was not seen any benefit. And that was, of course, because of dosing strategies that were not right. So the wrong dose, the number of injections was not right. But they learned on that, and they started doing further studies, and then they saw that they had some effect with omalizumab in allergic rhinitis. Now, at that time point, it was a new drug, very expensive. There was not too much experience with biologicals in the field. So generally, it was seen that it was not a good target, allergic rhinitis, because the disease was seen as too mild, which is true for the most population, but not for a subgroup of severe patients. Now, there has been a lot of studies going on, and actually also the last years in Japan, actually, and with CAT. So there more recent studies, like in 2020, there has been good studies with omalizumab in Japanese cedar, and it's also there. This is a study here where it was used as an add-on therapy on the standard of care. They used omalizumab, and what you see here is that they get a better control of this Japanese cedar after omalizumab treatment allergy. So given on that, you can, and in that country, in Japan, it's now reimbursed for Japanese cedar or allergic rhinitis. So indeed, it could be that it could be used as in that state. Also, there has been a lot of studies combining omalizumab, for example, and allergen-specific immunotherapy. This is also one of the things that has been done. As you can see here in this table, so what they did here, they used omalizumab together with immunotherapy, and the idea was mainly first to see less side effects of immunotherapy, but of course current products, the tablets, the current injections are getting more safe. So the question is this really a big advantage? And indeed, it has been shown that you have an effect, and that maybe in the start of the treatment, it could be an effect to overcome the first, but it's not clear that this is a good way of going on. So I think omalizumab and allergen-specific immunotherapy has been studied, but I personally don't see the advantages of there. I more think of the more complex patients with allergic rhinitis, where immunotherapy, you can't cover all the allergens, could be a good target. What about dupilumab in allergic rhinitis? Well, at this stage, there has not been published primary focused phase 3 trials on allergic rhinitis, but there is some data coming from asthma trials where they looked in a post hoc analysis whether there was a difference there, and I will show you the results. Also, they try to combine dupilumab with subcutaneous immunotherapy to see whether you have advantages of that in for example, in IgG4 levels, but that was not the case. So there also they are trying to look what the place is. This is actually the trial on a post hoc analysis in patients with comorbid asthma, where you can see that indeed if you treat with dupilumab, that you have some good effect actually on perennial allergic rhinitis. But this is, of course, in a subgroup analysis, a post hoc subgroup analysis in an asthma trial. Also, here you can see the other paper where they looked for the RQLQ symptoms in those asthma trials with different dosing. So there is an effect, and based on that, they have started dedicated phase 3 trials, but we don't have the results yet today, so we can't give a definite conclusion what the place of dupilumab is in the treatment of allergic rhinitis. Now, recently there is also some evolvement in targeted specific allergen-specific antibodies, so monoclonal antibodies, for example, against cat allergen or against the BATF1 allergen, and you see that my name is also on that. So there was a phase 1 trial where we treated also in a part B, where we treated patients with an anti-BATF1 monoclonal antibody, sort of an IgG4 antibody, and we give an injection, and then we see that one injection can have an effect or we followed up for 113 days. And we did nasal allergen challenges. So this is not a real exposure during season, but it's just an allergen challenge. And we did also basophil activation test. What you can see here is that on the total nasal symptom score, when you do nasal allergen challenge, that you have a reduction in symptoms, not only nasal symptoms, also ocular symptoms, and also the PNIF, you can be improved. And surprisingly, still after 57 days, we had a clinical effect of this treatment. That could be interesting because, for example, birds in Europe is a season of maximum 2 months. So you're giving them one injection every season. That could be maybe a good approach. We also looked for skin prick tests to see whether that was a difference. And you can see even after 113 days, the skin prick test was still different. We also looked for birch, alder, and hazel basophil activation test. And you also could see indeed the effect on the basophil activation test. Interestingly, also on apple, which quite often has a cross reactivity, we had a good effect that stayed for 113 days. For grass pollen as a control, we didn't see the effect. Recently, there is also a similar study with cats. So this is also with nasal allergen challenge. And there is also a phase 3 trial for both the cat and for the birch. The birch study is finished, but I cannot disclose the results right now. I've seen them, but I can't disclose today. For the cat trial that was ongoing, we know that the cat trial has been stopped. We didn't see the results why, but they didn't continue. So clearly there in the study design, there might be a flaw. So taken together, what is the evidence for biologicals in severe allergic rhinitis? To my opinion, there is a clear need. I think for omalizumab, there is enough evidence to show that it worked, but I think probably it's too late because the parents, so to call it, of omalizumab will not invest further, to my opinion, in big trials in Europe to get it reimbursed, which is a pity because it's getting cheaper, this drug. But in Japan, it's reimbursed. So I hope still we could do something with that. Dupilumab, we know there are trials ongoing. Indirect evidence in asthma shows that it works, but we should find the targeted studies in allergic rhinitis, and they are not published yet. There are promising results with the targeted monoclonal antibodies for anti-BETV1 and CAT, but there also we have to wait and show you the phase 3 trials to give you whether this will be a useful approach or not. But I think it's very interesting evolution as well, and I'm convinced that for a subgroup of patients with severe allergic rhinitis, we do need better treatments and that biologicals will be the option. I want to end with this nice picture of Klaus's retirement event we organized in Ghent, and to celebrate 30 years of research with an excellent group and team. Thank you very much.
Thank you, Philippe, for this very nice presentation. Are there questions from the panel or from the group? I have one question for you, Philippe. Do you think this will also work for food allergies?
Well, that's indeed an excellent question, Thibault. During the trial, we didn't stimulate patients to eat apple. But from what they told us, we know that they did, and they were happy with it. Of course, this is not a proof. This is not what we should do. So we should really go for targeted trials where we do food provocation and see whether this works. And if this works, this opens interesting doors also for other food allergies. Mm-hmm. But as you know, the anti-BETV1 has a cross-reactivity with apple, so that might be a good way to show, or a good beneficial effect on top of the allergic rhinitis effect.
Okay, thank you. Other questions?
So, Philippe, if I may, I have a question for you. It's related to these trials. So, was applying for the trials for biologics to use in allergic rhinitis more challenging than to use it in CRS and nasal polyps?
No, not at all. You find a lot of volunteers. Patients are really interested in getting that, and it's a more prevalent disease, so it's actually quite easy to get the patients. That's, I think, not the issue. The issue is, of course, the cost, to my opinion, whether
Yes,
a
the
biologicals
approval.
will be cost effective. But like omalizumab is dropping in price recently, and it will get quite competitive to some kind of immunotherapy treatment. So everything comes with a price, but if you wait 10 years, the price is different. We all know that. And that's the biggest challenge, is the price versus the severity of the disease. But there is a subgroup of patients where we really need better things.
Thank you.
I have a small question. Can I ask you a small question? In your graphs, it seems to be that at a certain time point, there is like some kind of rebound of symptoms again, or of values that are being measured, like at really late time points?
I think you mean in the anti-BET-V1 trial, we give only one injection, and then we follow it up for 113 days, which is longer than the average birch season. So indeed, we do know that after 3 months, the effect is going down, because also the antibody is going away based on pharmacokinetics. But for covering a season in Northern Europe or Northern America, that's just fine to get one injection just before. So it's weaning, and that is, of course, the disadvantage of this passive immunization, is that you have to treat every year, which is different from immunotherapy. You treat it 5 years, and then you have a long-term effect, which might last for 10 years. Here, you will have to do that every year. It's not a disease modification thing. It's passive immunization. So that's a disadvantage, but think about the potential of giving one injection every year just before the season. Well, could be a game changer for some targeted patients.
Yeah, I didn't realize it was only one injection. I didn't realize that, so thank you.